Hello and welcome to a 5-minute dermatology lecture on impetigo. My name is Tim Gravel, I'm a nurse practitioner student from Auburn University, and today I'm going to be talking to you about impetigo. Impetigo, also known as school sores, is a contagious skin infection, most commonly seen in school-aged children, hence the name school sores. The infection is usually present on the face, around the nose and mouth, and the extremities. It's usually caused by the bacteria Staphylococcus aureus, and sometimes it's caused by group A Streptococcus. On occasions, you can see both bacteria types present in the infection. There are two main types of impetigo. There's the bullous impetigo and the non-bullous impetigo. Bullous impetigo makes up about 30% or less of the cases that are seen. With bullous impetigo, you'll have small to large bulli that are fluid-filled. These fluid-filled vesicles will eventually become flaccid and burst, leaving a brown crust. You may also notice that these bulli are present on the trunk, which is less common in non-bullous impetigo. Non-bullous impetigo, which makes up approximately 70% of the cases, presents a little differently. With non-bullous impetigo, there's red ulcerations that have a characteristic honey-colored crust. Risk factors for developing impetigo are poor hygiene, pre-existing skin conditions such as eczema, trauma to the skin, thus allowing bacteria route to enter the skin, humid environments, and you will most often see impetigo in the summer and fall months, and also crowding, so your schools, daycares, and orphanages. When interviewing your patient or patient's family for that matter about the potential chance of them having impetigo, it's important to ask about the presentation of the rash early on. Typically, the impetigo rash will present as a macular or papular rash that may be just one or two spots, and then it'll develop into several spots. You may end up having satellite lesions. These lesions eventually become ulcerations, and you'll have the characteristic honey-colored crust. You may also want to ask them if the lesions are painful. Typically with the non-bullous impetigo, the lesions will be very tender to the touch. This can help differentiate between a contact dermatitis, which usually presents with pruritus or itchiness. Another important question to ask is questions that discern if there are risk factors involved. Ask if the patient has had eczema or scabies, if they scratch their skin or have had recent trauma to their skin, or if they're in environments like schools or daycares where they're crowded around children, and ask if other children may have potentially had this rash. On physical exam, you would expect to find red superficial lesions that have a honey-colored crust. They're typically going to be gathered around the nose, mouth, and extremities, and satellite lesions will most commonly be present. Another exam finding is that non-bullous impetigo is going to be tender to palpation. This is not common, however, in bullous impetigo. A third and final common finding in the physical exam for impetigo is that lymphadenopathy may be present locally to the infection. Now let's talk about treatment options. The first-line recommended treatment for non-bullous impetigo is mupirocin 2% topical ointment. This will be applied 3 times a day for 7 days if it's a minor spread, or 10 days if it's widespread. You'll also want to inform the patient to wash the lesions with antimicrobial soap and remove the crust at least twice a day. For more severe infections, or infections where it might be hard to reach with ointments, or in the case of bullous impetigo, beta-lactam antibiotics are the recommended choice. When prescribing oral antibiotics for children with impetigo, cephalexin 90 mg per kilogram per day divided into 2 or 4 doses for 7 days is the common regimen. Adults can take 250 mg by mouth 4 times a day for 7 days. If MRSA is suspected or confirmed, there are a couple of other oral antibiotic regimens that you may want to consider. Clindamycin 10 to 20 milligrams per kilogram a day divided into 3 or 4 doses for 7 days in children, or adults can take 300 to 450 milligrams 4 times a day for 7 days. You may also use trimethoprim sulfamethoxyl 8 to 12 milligrams per kilogram a day divided in 2 doses every 12 hours for 7 days in children, or the double strength tabs 1 or 2 twice daily for 7 days in adults. It is important to know that penicillin and amoxicillin are no longer recommended for treatment of impetigo. After prescribing these medications, you'll want your patients to follow up in 7 to 10 days to ensure clearing. If the rash has not improved or the lesions have worsened, at this time you should obtain a culture to further investigate the source of bacteria. Now let's move on to teaching components for patients and parents. The most important thing you can teach your patients that have impetigo is that they must wash their hands and wash their hands frequently, also avoiding skin-to-skin contact with others as to prevent the spread of the infection. Typically, impetigo heals with little to no scarring. It is important to let your patients know not to scratch these lesions, as the scratching may eventually lead to scarring as it deepens the wound bed. An important teaching method, therefore, for patients would be to have them clip their fingernails or also to keep their wounds covered with a gauze dressing to prevent scratching. For pediatric patients, it's important to let parents know that after applying ointment to their children, they should also be washing their hands. They need to take all of the bedding and clothing of the child and wash it separately from others in the household, as well as disinfecting any surfaces that the child has come into contact with as to prevent any spread of infection within the house. Thank you so much for watching today. I hope you learned something new about impetigo, and I hope you have a great day.